All right, hello everyone and welcome to Assisi University. Today's lecture will be latest updates on intervertebral disc disease. Our speaker, Dr. Deirdre Chiaramonte, received her DVM from Tufts University School of Veterinary Medicine. She's a diplomat of the American College of Veterinary Internal Medicine, and she was the director of the Tina Santi Flaherty Rehab and Fitness Unit of Animal Medical Center in New York. Dr. Chiaramonte is certified in canine and equine rehabilitation and acupuncture. Current interests are in the field of rehab, obesity, and geriatrics. Deirdre is currently the president of the Veterinary Medical Association of New York City and is the director of clinical education at Assisi Animal Health. We welcome Dr. Chiaramonte.
Hello, everybody. Thanks for joining us today. I hope everybody fared well with yesterday's storm and everybody has power. So we're going to cover some of the updates in, my slide's not working, updates in vertebral disc disease, a lot of publications that are coming out about this disease process that we all work with so frequently. So we're going to cover types of disc disease, patient evaluation, when to do surgery, steroids versus NSAIDs, and post-operative care and rehab. So first will be types of disc disease with a little bit of history. So the first report of intervertebral disc disease in a dog was published way back in 1881 and involved a dachshund with an acute onset of hind limb paralysis. It would take over 40 years for the condition to be correctly described in the veterinary literature. Intervertebral disc degeneration is an imminent effect of aging in dogs. During the 1950s, studies of intervertebral disc degeneration in dogs were performed by the Swedish veterinarians Hansen and Olsen. We all learned about Hansen. And their research led to the first clear description of intervertebral disc degeneration and herniation and explained the distinction between chondrodystrophic and non-chondrodystrophic breeds with regards to this process. And the literal translation of chondrodystrophy is cartilage maldevelopment. All right, so the healthy intervertebral disc is composed of four distinct components: the nucleus pulposus, the annulus fibrosus, end plates identified by the arrows, and the transition zone. During motion, the canine intervertebral disc can be subjected and is subjected to several motions and loading conditions, such as axial compression, tension, bending, and torsion. The components work together as a functional unit to resist all these different loads. Intervertebral disc degeneration is an aberrant cell-mediated response to progressive structural failure associated with genetic predisposition, chronic physico-mechanical overload, trauma, inadequate metabolite and nutrient transport within the disc matrix, cell senescence and death, altered levels of enzyme activity, changes in macromolecules and water content. The disc will lose its hydrostatic properties and can't function as a cushion anymore. So there's a new scheme for grading the histopathological changes in the canine intervertebral disc, and it's been recently proposed by Bergnut et al. In 2012, which not only evaluates the cellular and structural changes in the four zones, but also considers changes in the tissues or structures adjacent to the disc. And this is really the first update we've had since Hansen. So here are examples of intervertebral disc degeneration ranging in grades from 1 to 5. Now, it does not include herniation or the prolapse of the intervertebral disc, which are the consequences of the degenerative processes. And you guys can all follow that histopath and see the big bunch of differences between grade 1 and grade 5. Histopathology of bones of chondrodystrophic puppies showed that their short stature is due to defects in the enchondral ossification, whereby cartilage is replaced with bone in the developing limb. Although it would seem plausible that a disproportionately long spine relative to short legs might predispose them to disc degeneration, no association has been found. Now, the lumbosacral junction of non-chondrodystrophic dogs permits considerable mobility in flexion, extension, rotation, and shear, making it more susceptible to instability. There's also an imbalance between the dimensions of lumbosacral contact area and body weight, such that the lumbosacral junction in large breeds may be subject to proportionally higher loads, leading to intervertebral disc degeneration. And our favorite LS cases, male German Shepherd dogs at the highest risk of developing intervertebral disc degeneration at L7 to S1. The facet joint angle of L7 S1 is more oblique than those of other adjacent vertebra. And this oblique orientation causes a disproportionately high workload, predisposing that disc to degeneration. Additional histopath differences include the transition zone of chondrodystrophic puppies is relatively wide. Its degeneration occurs earlier and faster than a non-chondrodystrophic dog breeds. The nucleus pulposus dries up, causing a degenerative change in the annulus fibrosus. It progresses rapidly and can result in sudden herniation by the age of 2. So on the left is transverse and the right is sagittal sections through the L5, L6 intervertebral disc of a 2-year-old chondrodystrophic dog, showing a dorsally located drier nucleus pulposus, a widened transition zone, and a normal annulus fibrosis. Then we can compare transverse sections through the L5, L6 intervertebral disc, healthy on the left and unhealthy on the right of that 2-year-old puppy. Now comparing the sagittal sections through that same intervertebral disc, again, healthy on the left and unhealthy on the right, we see all this degeneration occurring at a pretty young age. Back to Hansen, type 1 intervertebral disc disease typically occurs in small breed chondrodystrophic dogs. Continued disc degeneration leads to altered disc biomechanics. With repeated abnormal forces on the disc, the dorsal portion of the annulus fibrosus becomes weakened, and the mineralized nucleus is acutely extruded into the vertebral canal to cause a sudden onset of pain and neurological dysfunction. The light gray is the annulus, the dark gray is the dorsal longitudinal ligament, and extrusion of the yellow nucleus pulposus. And here's imaging of a type 1 intervertebral disc case. It generally reveals spinal cord swelling, cytotoxic edema, and a ventrolateral extradural compressive lesion caused by an acutely extruded nucleus pulposus with variable hemorrhage, as seen in this MRI. And in a while, we're going to get back to edema that becomes important later on in our anti-inflammatory choices. In type 2, intervertebral disc disease typically occurs in the non-chondrodystrophic large breed dogs. There's a fibrous metaplasia of the nucleus pulposus and concurrent degeneration of the annulus fibrosus. This degenerative process leads to bulging of the nucleus pulposus with the weakened annulus and a gradual dorsal protrusion into the vertebral canal. Clinical signs are most commonly observed in geriatric animals. Pain and neurologic dysfunction in this case results from the chronic compression of the spinal cord and nerve roots, which leads to gliosis, vasogenic edema, and atrophy of the spinal cord. And that imaging is here. Type 2 intervertebral disc reveals a ventral midline extradural compression composed of smooth, rounded, protruding annulus. The spinal cord often has an appearance of being draped over the protruding disc because of the chronicity of the compression. Type 3 intervertebral disc disease has now been reclassified as ANP, or acute noncompressive nucleus pulposus extrusion, where disc material has been shot through the cord. These are also called missile discs, traumatic discs, high velocity, but low volume, and similarly managed to fibrocartilaginous emboli. Now, a word about calcification, which is a process associated with intervertebral disc, frequently observed in chondrodystrophic dogs, but rarely in non-chondrodystrophic dogs. Intervertebral disc calcification can be found at all spinal levels and can be seen as early as 5 months of age, but appears to reach a maximum at about 2 years. An increase in the total number of calcified discs is associated with the risk of developing herniation, but at random spinal levels. And although calcification can affect intervertebral disc integrity, and calcified discs can herniate, calcification occurs much more often than intervertebral disc herniation. It's not uncommon, and also classifications can also be resorbed. All right, so the typical presentation is a few days of something's not quite right, and of course, you get the owner coming in where I picked up my dog and he screams, so I think something's wrong with his stomach. Although dachshunds are clearly overrepresented, the Trunci is gaining speed. And most of those pictures I poached off the internet, except the bottom right, that's Fenton. He's a 3 times frequent flyer. All right, so grabbing some pet insurance data. Overall, intervertebral disc disease is a small percentage across all dog breeds, but obviously a big issue of up to 62% in dachshunds. So is there any good news coming out at all? Well, you'd like to think there's some. A new recent finding, a group at UC Davis reported the identification of fibroblast growth factor, FGF4, retrogene insertion on chromosome 12, and it's responsible for chondrodystrophy and an increased risk of intervertebral disc disease, which fortunately or unfortunately has a 50-fold risk of having intervertebral disc disease. Through UC Davis, genetic testing is available, and we're hoping that breeders will take advantage of it. So I pulled this off the UC Davis website. It's pretty interesting, just all the cool research being done with this disease process. All right, so let's go to patient evaluation. And to help reach a prognosis in non-ambulatory animals with spinal cord disease, you have to assess voluntary motor function or pain perception. Evaluating superficial pain perception by pinching the toe web with a hemostat, and evaluate deep pain perception by pinching the toe, the periosteum. Again, withdrawing the limb is a withdrawal reflex. It doesn't mean the animal feels the pinch. A positive result in pain perception test is the animal showing a conscious response to the stimulus, like that dog trying to get up and look back, trying to bite, whining, etc. It's not enjoyable, but it needs to be done. Go back. Okay, so we start with a good neuro exam. We localize the signs, grade the severity as follows. Grade 1 is spinal pain only, no neurodeficits. Grade 2 is ataxia and weakness. Grade 3 is non-ambulatory paraparesis. Grade 4 is paralysis, and grade 5 is paralysis without pain perception. So what are we going to do for diagnosis or imaging? Spinal radiographs may show evidence of disc degeneration and may show signs of herniation with a narrow disc space, opacification of the intervertebral foramen, but a definitive diagnosis we know is only established with advanced imaging using MRI or CT or myelography. CT can be used to diagnose mineralized disc herniations very effectively, but obviously fails to identify soft tissue herniations without concurrent myelography. So MRI is specific and sensitive and can give prognostic information, but is more expensive and less readily available. Now this doesn't really fit into any place except it needs to be mentioned. Spinal shock is the loss of muscular tone and segmental spinal reflexes that develops caudal to a severe spinal cord injury. Although little recognized in the veterinary literature, spinal shock occurs in animals and is important in case management, especially for veterinarians in the primary care centers who are likely to see the animals in the period immediately after the injury when the spinal shock is most marked. Spinal cord perfusion becomes dependent on mean arterial pressure and is therefore poor during spinal shock. The initial spinal injury can appear markedly worsened as ischemia and hypoxia develop. Spinal shock persists for a variable length of time in different species and is followed by a gradual return of reflexes. So this is why you have to do repeated neuro exams on your patients, because a lot can change. The presence of pain perception is the most important prognosticator that there is. All dogs with intact pain perception have the ability to recover motor function and continence. So when to do surgery? When to do surgery? It is really appropriate to refer any dog that cannot walk ASAP. Now, that doesn't always happen. So we go with our prognosticating of type 1 intervertebral disc disease, grading 1 through 5 on the left, and we see that with conservative management, medical management of these cases, they have about an 80 to 90% chance of recovery. If they do have surgery, which would be a little extreme in those grades, over 90%. As we go down to grade 3, about a 70% chance with conservative treatment, over 90% with surgical treatment. And then when we get into grades 4 and 5, those percentages start dropping. Now, this is basically, I think, what people have learned over time. Everybody who does either neurosurgery or neuro rehab a lot, they have their own, probably better, but this is sort of the national pool of what is known. And what we do know is that when we treat these animals conservatively, they tend to recover more slowly and to a lower level. And there is an increased chance of recurrence because we haven't taken away that injury. Conservative treatment allows the spinal cord to recover, but again, without surgical decompression, the cord still has that sitting there. So important to keep in mind. So conservative management is appropriate for grades 1 and 2, acceptable for grades 3 and 4, really not the best choice at all for grade 5. Strict confinement for 4 weeks, pain management, rehab, and the patient should be improving within 2 weeks and making strides after that mark. So the aim of surgery is to decompress the spinal cord, and there is a reduced risk of recurrence with that cord taken out of there. So surgical treatment recommended for grades 3 through 4 in all non-ambulatory dogs, really vital for grade 5, and actually acceptable after recurrent bouts of pain in grades 1 and 2. And postoperative management follows the same guidelines as conservative management. All right, so what about the timing of surgery? So if they can't walk, but they can feel, usually better within 24 hours. If they are paraplegic without sensation, what does the research show? So I've taken a bunch of papers and tried to highlight the differences between the two. And it's really, even though we're dealing with the same type of condition, it's really difficult because they don't all follow the same protocols. So, all right, this paper was done at Iowa State and used 78 dogs with complete loss of deep pain perception in the pelvic limbs and tail, and it had decompressive surgery. Factors noted were signs prior to onset of paraplegia, delay between onset of paraplegia and initial referral evaluation, date of recovery or locomotion or euthanasia. And they looked at also, which is really great for us, whether dogs had received steroids before surgery. And this paper, comparing it out of North Carolina State, where they graded neurological deficits before surgery and followed them over a period of 3 to 6 months, and some to finally over a year out. And they recorded neurological improvements, time to ambulation, fecal and urinary incontinence. Iowa State demonstrated that 45 to 78 dogs, 58%, recovered the ability to ambulate within 3 months of decompressive surgery. No prognostic indicator was identified. Most importantly, a greater delay between onset of paraplegia and referral was not actually associated with a poorer prognosis, but these dogs, the dogs that were delayed having surgery, had a higher incidence of progressive myelomalacia. And dogs that were cut while still ambulatory had less fecal and urinary incontinence compared to the paraplegic dogs. That kind of makes sense to me. So we will talk about progressive myelomalacia in a minute. But this paper was just actually published. It's a retrospective study out of the University of Bristol, published in the Journal of Small Animal Practice in April of this year, and compared dogs with TL disc extrusion that lost pelvic limb pain perception when surgery was performed on the day of admission versus delayed overnight. So 273 dogs, they were able to comb through the records with disc extrusion, intact pain perception, but unable to walk, were divided into two groups. One, early surgery. So spinal decompression between their examination day of admission and the following morning. Or two, delayed surgery. They did not undergo surgery between admission and the following morning. The proportion of dogs that lost pelvic limb pain perception overnight was compared to the early and delayed groups. So 7 out of 151 dogs in the early surgery group lost pain perception overnight, compared to 15 of 122 in the delayed surgery group. 5 of those 7 dogs that lost pain perception in the early surgery group recovered pain perception by 3 weeks post-op, so that's pretty good, compared to 8 of the 14 in the delayed group. So this study suggests that an overnight delay before spinal decompression increases the risk of clinically meaningful deterioration in dogs unable to walk following disc extrusion. All right, this paper out of London compares ischemic myelopathy, fibrocartilaginous emboli, and ANP, all common neurologic emergencies in dogs that have similar clinical signs, such as hyperacute, non-progressive spinal cord dysfunction, with or without signs of pain. FCE causes a rather sudden onset of regional ischemia, resulting in necrosis of the spinal cord parenchyma. In contrast, ANP is suspected to cause a contusion rather than ischemic injury. On presentation, ANP dogs are usually older, larger, and have more damage, but those without pain sensation are usually euthanized. Let's look at some good, I love this paper, good prognostic indicator following surgery, and the most inexpensive test there is, the cutaneous trunci muscle reflex. So it's a relatively complex reflex elicited by applying a stimulus to the skin, which stimulates the superficial spinal nerves that innervate a particular region of the dermis and elicits a motor response. Response is the skin twitch, as you see there. This test can be used to help localize spinal cord lesion. If a response is absent, the lesion is 1 to 2 vertebra cranial to this level, as the sensory nerves travel slightly cranially before synapsing. So, again, out of North Carolina State University, 36 dogs with intervertebral disc extrusion causing paraplegia in pelvic limbs were included. 24 hours postoperatively, the caudal border of the cutaneous trunci muscle was established, and then again at discharge. The reflex was reported as moving cranially, which is not good, caudally, which is good, or staying in the same place. Dogs were reevaluated at 12 to 20 weeks and 7 to 36 months. Outcomes were reported as improved, unimproved, or ascending myelomalacia compared to the 24-hour post-op cutaneous trunci muscle reflex. Always a mouthful. So, cutaneous trunci muscle reflex progression was caudal, good, in 19 dogs, static in 11, and cranial in 6. 17 of the 19 dogs with caudal moving cutaneous trunci muscle reflex showed an improvement by 12 to 20 weeks, and that makes sense. 5 of the 6 dogs in the cranial moving cutaneous trunci muscle reflex developed ascending myelomalacia, which is a bummer. So what else is out there? Some of the newer technology, or sort of improved technology. Medical infrared imaging, or thermography, is a very non-invasive imaging modality that measures and graphically displays skin temperature patterns. Using body surface temperature measurement as a modality of medical assessment, it's not that new, and actually this is pretty cool. Its origins date back to the Greeks, who covered the human body with mud and observed the patterns formed as the mud dried. The temperature of the skin region, called dermatome, is directly influenced by its perfusion and is under control of the sympathetic nervous system. Any process that disrupts the sympathetic control of the dermatome will alter its perfusion and thus change the surface temperature in the thermographic pattern. So this study compared thermography with MRI results and surgical findings. They took 58 chondrodystrophic dogs with type 1 intervertebral disc disease and 14 without intervertebral disc disease. all dogs had complete neuroexaminations, thermography, MRI, and any dogs with intervertebral disc disease underwent surgery. The results showed that thermography was actually 90% successful in differentiating normal dogs from intervertebral disc disease dogs, and 97% successful in identifying an abnormal intervertebral disc space. So anybody who actually has thermography in their practice might want to start scanning these dogs and see what you can find. All right, steroids. Well, it's complicated. So where did the rationale for steroids come from? Well, let me go back to edema. So I mentioned that before. Vasogenic edema is an extravasation of fluid and serum proteins by blood-brain barrier disruption. Injury, which leads to inflammation, oxidative stress, glial activation, which commonly happens in chronic type 2 and neoplastic cases. Cytotoxic edema is astrocyte swelling leading to outflow of intravascular sodium and fluid. This injury causes ATP depletion, mitochondrial dysfunction, and oxidative stress. And this more typically happens in acute type 1, type 3, and fibrocartilaginous emboli. So when using steroids, there's always many ways to do it. Do we do immunosuppressive, anti-inflammatory, ultra-high dose? Do we think that's neuroprotective? Are they really indicated? And what is the right scenario? And where did we actually get the rationale for steroids from? So the rationale for steroids in acute spinal cord injury stems from the National Acute Spinal Cord Injury studies, first in rodents, then in humans. Class 1 studies used low-dose methylpred, which was ineffective. Then high-dose methylpred was used, which produced a small benefit, especially if used in the initial 8 hours. The third class of testing used various dosing schemes. Free radical formation and excitotoxicity are central to this pathology of spinal cord injury. Many different drug therapies can target this secondary injury cascade, improve the outcome experimentally, but they haven't really shown any clinical benefit. All right, how about some more research out of North Carolina State University? Dr. Olby, I'm one of her biggest fans. Her team compared polyethylene glycol with methylpred in intervertebral disc herniations. 63 dogs with complete grade 5 herniations were randomized to either receive methylpred at 30 mg per kg or polyethylene glycol, and neurofunction was assessed. Only 47% recovered ambulation and 17% developed myelomalacia, and there was no benefit found with either methylpred or polyethylene glycol. So what can happen with steroids, and can we prevent it? Here's a JVIM paper examining gastromucosal lesions of intervertebral disc patients receiving omeprazole and misoprostol with steroids, and unfortunately they found no protective effects in preventing mucosal lesions. Here's another study, this one published in JAMA, examining adverse effects and outcomes associated with dexamethasone administration with acute intervertebral disc herniation. This is a retrospective study. They were in 3 groups: those that received dexamethasone less than 48 hours pre-admission, second, those receiving another glucocorticoid less than 48 hours of admission, and 3 receiving no treatment. The dexamethasone dogs treated were 3.5 times more likely to have a complication versus other or no glucocorticoid. Dex-treated dogs also had more UTIs and more diarrhea. And the kicker is that there was no difference in neurofunction between the groups. This study from Texas A&M was a retrospective look at the success of medical management of cervical. I know it's not TL, but they were still ambulatory at presentation, and results showed that medical management can lead to an acceptable outcome in many dogs with presumptive cervical disc herniation. But these dogs also often failed. All right, this study, retrospective study, JVIM 2017, most of the studies showed that progressive myelomalacia can appear at onset of clinical signs and up to 5 days out. So also important to trace that cutaneous trunci muscle reflex. They were able to tease out of this study that low doses of steroids did actually reduce the risk of progressive myelomalacia significantly. So that's probably our first rationale of using low dose steroids. So what are we left with? Should we use corticosteroids for acute intervertebral disc herniation? So obviously the difficulty with addressing this question is complex. How much of the corticosteroid, which one, which route, for what reason? And so the use of steroids can be simplified into 2 main rationales. The first is to treat pain and inflammation associated with disc herniation using anti-inflammatory doses of prednisolone or dexamethasone over a 5 to 10 day period, whether or not surgery is performed. And there's absolutely no data to support the use of corticosteroids in this way. And I think that's along the way, you know, they get comfortable with what they have been using in their experience, and they will have a lot of anecdotal information, which is fine. We all thrive on that. The arguments against corticosteroid use in this way is that they may be effective at reducing pain and inflammation, but they could be detrimental and delay pursuing a complete diagnostic workup. And if the old adage goes, if we actually take away their pain, they might be more active and cause additional disc herniation. And also, steroids, we know, sometimes can inhibit healing of the annulus fibrosus and the spinal cord. So, postoperative care and rehab. All right, this study evaluated time to walking following surgery. So in this paper, they deemed that walking took 12.5 days from the date of surgery. In this study, they were actually able to tease out that walking was successful within 10 days. Both studies showed that the presence of postoperative voluntary motor function was a favorable prognostic indicator, of course. And just a note, because of the myriad of different studies on intervertebral disc disease, you have to tease out what is their success, what is their primary outcome measure and their secondary outcome measures. So some of the studies that use 10 steps as a success versus a few, some papers actually use 3 steps. So there's a big difference in what people are considering a success. So just when you're perusing your journal articles, just pay attention to that. So how about some recent success brought to you by our sponsor, Assisi Animal Health. This recently published paper in Research in Veterinary Science. It's also an excellent review on PMF, its history, and its applications. So PMF is an active electromagnetic waveform that cannot be felt. It ultimately enhances nitric oxide production, affects heat shock proteins, cellular policemen, and is a potent driver of the anti-inflammatory process. In the initial bench work for FDA lab work, which all non-steroidal type anti-inflammatory things, medications, devices have to do, they have to use the carrageenan rat model. And PMF actually was comparable to NSAIDs in the standard model of inflammation. Mimicking the human data, the canine clinical trials showed an anti-inflammatory effect, pain reduction, and opioid sparing, which is really important these days. So this was published in the Journal of Neurotrauma. The study at North Carolina State by Dr. Olby and colleagues used dogs with complete grade 5 intervertebral disc extrusion. Upon diagnosis, the patients were treated with PMF immediately, even before surgery, and they had a PMF loop or a sham loop every 2 hours for before and after surgery. And 2 weeks, at the 2-week mark, they were then treated twice daily for another 28 days. Neurological assessments, pain, and biomarkers were measured, and what they found that was within 24 hours, there was a significant decrease of incisional wound pain based on mechanical sensory testing, that algometer in the upper right-hand corner. Proprioceptive placement was better in the PEMF dogs by day 42. And glial fibrillary acidic protein, a marker of spinal cord injury, was significantly less in the PEMF-treated dogs. And just like the inexpensive cutaneous trunci muscle reflex test, Dr. Olby is on a quest to have a cage-side test, one to diagnose the amount of spinal cord injury and hopefully be able to use that as a prognostic indicator for owners. This study out of the Animal Medical Center in New York, 53 dogs with grades 2 through 4 intervertebral disc had hemilaminectomies. It's a different protocol, but the loop or the sham was applied every 6 hours post-op until discharge, and then twice daily until post-operative day 7. This revealed, the study, better neurological scoring, better incisional pain and wound scoring. PMF dogs walked in half the amount of time as sham dogs, and mirroring the human research, sham dogs took almost twice as much codeine. One of the couple things that are wonderful about this research is Dr. Alvarez won an ACVS MR Research Award. And another thing, just sort of one of the caveats, is that even though they were randomized into 2 different groups, the PEMF group had worse neurological scores to start with. So they did better even though they were actually graded worse. All right, should we crate rest our patients? Depends on disease and lifestyle. Crate rest usually 4 to 6 weeks for type 1 and type 3, and then a gradual reintroduction for, kind of give owners another 4-week and another 4-week time period, and then modified activity level and lifestyle for these guys going forward. All right, so acupuncture, which is really a wonderful tool in these cases. When a needle is inserted into and rotated into the skin, collagen and elastic fibers wind and tighten around the needle, causing a mechanical coupling between tissues and the needle. It first causes deformation of the fibrin matrix, pulling on nerve endings and fibroblasts, and may be interacting on type 1 and type 2 muscle spindles. Then there's a whole bunch of cellular responses following, leading up to gene expression, protein synthesis, neuromodulation, which can continue after the needle is withdrawn, or if you decide to use aquapuncture or something like that. The needle impulse, such as acupuncture, bombards the dorsal horn, causing a transient overload, leading to a decrease in transmission of the pain signal. So I love acupuncture in these cases. In this paper, JAVA, they compared postoperative pain in dogs that had undergone hemilaminectomy. One group had a hemilaminectomy plus traditional analgesics. A second group received conventional analgesics and electroacupuncture. Blinded pain scoring revealed that the total dose of fentanyl administered to the electroacupuncture cases was lower than in the control cases, and that pain scoring was lower as well. In this study, they compared decompressive surgery, electroacupuncture, and decompressive surgery followed by electroacupuncture for the treatment of dogs with intervertebral disc disease with long-standing severe neurological defects. This is a prospective clinical trial compared to historical data. So some people don't like these studies, but we do the best we can with the information that we have. They took 40 dogs with thoracolumbar injury, 10 received decompressive surgery, 19 received electroacupuncture, and 11 received both. Dogs improving to the grade 1 or 2 category were considered successes. And in this study, actually, the electroacupuncture group performed much better. All right, so what are we doing for pain management? NSAIDs, probably this is the way I usually go now instead of steroids. Opioids play a very significant role in action on descending nociceptive or sensory neuron modulatory pathways. Muscle relaxants such as diazepam or methcarbamol are very helpful when the pain is due to muscle spasm. And we know that these little guys, either their cervical necks are screaming, they have cervical issues, or they've been dragging their hind limbs around with their front limbs. So they're just a ball of muscle spasms up front. NMDA receptor antagonists also play a role in analgesic therapy, as their effect reduces central sensitization, which is really important, and hypersensitivity. Gabapentin is well tolerated and can be helpful in the multimodal pain management plan. So I forgot where I grabbed this a while ago. I'm not sure how many people are using tramadol. There's a whole, bunch of discussion on tramadol, not helpful in orthopedic cases. Soft tissue may be different. Cats are different as well. But gabapentin, we know and love. NSAIDs, Pred, Robaxin, and Valium. All right. Should we recommend rehab for intervertebral patients? Well, we would all scream yes. However, also published out of North Carolina State was this randomized blinded clinical trial of postoperative rehab in dogs after surgical decompression of acute thoracolumbar intervertebral disc herniation. They were randomized to a basic or intensive 14-day in-house rehab protocol. They did open field gait scores, so walking and coordination were primary outcomes. Secondary measures were gait, postoperative pain, and weight placement compared at 14 and 42 days. So out of 50 dogs screened, 32 met the inclusion criteria and 30 completed the protocol. There were no adverse events associated with rehab. Median time to walking was about 7.5 days. Mean change in open field scores was 6 days versus 5 days, representing no difference in treatment effect versus the intensive rehab post-op, which is a bummer. None of the outcome measures were really different. So they concluded that early post-op rehab after surgery for thoracolumbar intervertebral disc herniation is safe, but doesn't improve the rate or level of recovery in dogs with incomplete spinal cord injury. And I don't know why this, I love that somebody went and did this research, but I can't figure out why exactly it didn't work, because we all know that it works very well. At least we feel it does. All right, so I think we would say yes. And we would also want to add in our non-pharmaceutical anti-inflammatory devices for helping these cases. So in addition to PEMF and acupuncture, laser, neuromuscular stim is really, really important in retraining those nerves and atrophied muscles, massage, mobilizations, etc. Neuroplasticity, the window is pretty large. It's like 9 to 12 months a year, so you have a lot of time to play with these dogs. Some of the other neurological injuries that we might see would be brachial or lumbar plexus injuries, and they can really go on for a long period of time, and you don't think you're making a difference, but I don't like giving up on them. No deep pain, months and months and months and months. I think my longest standing no deep pain dog that finally came around to walking was a pretty overweight beagle who took almost a year. And just one note I learned on a different webinar, because that's how we're doing our lives these days. In a human relearning to move one joint based on research, it takes over 1,300 repetitions of retraining all those mechano-neuroreceptors in that joint. In an average therapy session, we do maybe 25 to 35 cycles. So it's really mandatory, besides what we do in the clinic. It's mandatory for caregiver participation and a home exercise plan. And also, don't forget that there are really fabulous supportive and assistive devices to help these dogs. All right, so besides NPEDs, there should be daily neuro rehab focused on current functional status. So joint approximations to stimulate weight bearing in both recumbent and assisted standing. So while they're laying down, that's fine. You're going to help them do joint range of motion, etc. But then get these dogs, these little Frenchies, up on a physio ball so they could be standing in the correct posture. And in any postures that they are, sitting, standing, make them be correct, because we want to train all these neural pathways and muscles correctly. Help assisted rising with manual correction of the paw. And also what really helps is neurosensory stimulation of the paw. So those BOSUs with the little tactile nubs on them, land treadmills. I know this is not necessarily a rehab lecture, but land treadmills with the belt, underwater treadmills, all that repetitive neurosensory stimulation helps these guys move forward. What else? It's important to discuss proper care of a down dog. One is bladder care. We don't want them to overfill the bladder and cause additional neurologic issues. The patient must also be frequently checked for urine scald and decubital ulcers. Skin is tough. It's really tough, right? Requiring hundreds of pounds of pressure per square inch to penetrate the skin. But a constant unrelieved pressure as low as 1 pound per square inch can do damage. So if these dogs are continually laying on one side, all those bony protuberances, you might find some damage to that skin. So please frequently check and turn your patients. And also remember that for every 1 day of disuse leading to atrophy, it takes more than 3 days of rehab to get it back. All right, so in conclusion, there is more to a disc than a dachshund. They come in all shapes and sizes, different types of spinal cord injury. Evaluate carefully for evidence of progressive myelomalacia. It's appropriate to refer anything that cannot walk. Follow the cutaneous trunci muscle reflex. Steroids, high doses, no, low doses, maybe, but probably NSAIDs are the way to go. Post-operative care should be very good pain relief, controlled exercise, lifestyle, and individual care going forward.